Hello, good evening, and welcome to another in the series of the Royal College of Surgeons of Edinburgh's webinar series. This is the webinar in conjunction with ACP-GBI on the impact of COVID-19 on colorectal surgery. I'm Neil Smart, I'm a consultant colorectal surgeon in Exeter, and I'm joined by three panelists this evening. We have Nicola Fernhead, who's a consultant colorectal surgeon in Cambridge and is president of the Association of Coloproctology of Great Britain and Ireland. We have Mr. John Abercrombie, who's a consultant colorectal surgeon based in Nottingham and is a council member of the Royal College of Surgeons of England. And we have Professor Angus Watson, who is a consultant colorectal surgeon based up in Inverness and is the RCS Ed Council member. First of all, I'd like to welcome everyone who has tuned in this evening and I'd like to thank you all for your hard work on the front line. We're going to start with a short presentation and we're going to go through a few things and discuss some of the topics that are up for discussion. And I think all of us will pitch in at some point and then we'll be taking questions. And I think the most important fact about tonight is the discussion that we're going to have after the relatively brief presentation. So I'd like to hand over to Nicola to start the presentation. Nicola, over to you.
Thank you, Neil, and a very big thank you to the Royal College of Surgeons of Edinburgh for hosting the webinar tonight and for inviting us all to join with them to add to their educational programme. I know we've got a lot to get through, but I want to start by just giving you a flavour of some of the things that ACP-GBI has been doing and how we might develop the conversation over this evening. Next slide, please. So this year, I thought we would be doing something completely different around now. We had planned our annual meeting and unfortunately that has since been cancelled. I guess you can't see much on the slide because I can just see cancelled. But what it does mean is that we have now moved into a completely different mode. And if I go to the next slide, please, Ryan, really talking about a completely different set of priorities from what we had intended when planning the Edinburgh meeting. A number of things that our members need in order to stay safe. So personal protective equipment, we've all heard a lot about it, safe surgery practices, looking at maintaining our emergency services, but also minimising the impact on our other colorectal patients. We have many trainees and members in completely new roles and they need support as well. We need to remain connected with each other, make sure that we get you updated and accurate information, support research, and most of all, maintain workforce morale. And in the midst of all this, we also need to start preparing for recovery and what might come next. Next slide, please. So you will be aware that we have contributed to the Intercollegiate General Surgical Advice, which was put out about a month ago, caused quite a lot of controversy and certainly got Public Health England and the other public health authorities thinking about what we should be doing, particularly for surgery. We can talk more about this during the webinar this evening. Next slide, please. John.
Thank you very much. So PPE, I think, is a very emotional subject. It's certainly, this crisis is the first and only time I've been frightened going to work, and the fear of this disease is considerable. As far as I'm aware, problems have not arisen with PPE provision in theatre. All hospitals are treating all emergency surgery as potentially infected cases, and appropriate equipment is made available. Both colleges have made it very clear, and the BMA has just weighed in as well, to say that if you do not feel that you have appropriate protective equipment, then you should not proceed, and you cannot be made to proceed with whatever it is that's proposed. In a way, you need to think about this a bit as though the same way as you would with a road traffic accident. You would not run out into traffic and put yourself at risk to deal with somebody who's just been knocked down. Only in this context, you take your whole family and your colleagues with you if you run out. So you must take time, make sure that you've got the equipment. But people ask, what happens if I have been exposed? And the answer there from both colleges is crystal clear. If you feel that you've been exposed, you need to finish the procedure and then isolate. And isolate yourself until you've been shown not to have the illness and you've had appropriate screening to come back to work. This is really very clear and should be straightforward. Next slide, please.
So when we start to look at our patients, many of us manage patients with colorectal cancer, and it's a very multidisciplinary team effort normally, which is a good thing in some ways because it does mean that we have some alternative strategies to offer patients when there is very little in the way of elective services happening. But we also have to think about the fact that there's very little in the way of endoscopy being carried out across the country at the moment, and that many patients will essentially have their surgery deferred for quite a lot of time, particularly if they're vulnerable. They may have different types of surgery carried out when they do get surgery, and some of the strategies we use may have to change in order to keep surgeons safe as well as patients safe. But we still do have the option of obstructing cancer being treated with a stent as a bridge to surgery, and we do still have the option of short course radiotherapy for patients with rectal cancer. We have to remember, though, that chemotherapy is a real risk for patients. And we know from the Chinese data that having chemotherapy or being on chemotherapy during the pandemic puts your risk of mortality up by about 2 decades, which is really an unpalatable thought for many patients when chemotherapy is largely an insurance option. Next slide, please. So the other thing that has been very difficult to manage is the rapid access colorectal cancer pathway. At the moment, we know that this pathway only yields about 3 to 4% of patients who are investigated actually being found to have colorectal cancer. And so what we're really trying to do is save that other 96 to 97% from being exposed to a hospital environment unnecessarily, while still screening out the highest risk patients, particularly those who might present as emergencies, and making sure that they're investigated appropriately and safely and get the treatment that they need. We've also started to give thought to how we're going to prioritise patients for when endoscopy services do become available again, and have given some guidance in terms of how we might do that. Where FIT is available, and it is in many parts of the country, it is a very good triage tool, and particularly if it can be done remotely and without a hospital attendance. Next slide, please. Patients with IBD often need surgery, and something that they frequently fear, but at the same time often need in terms of life-saving or life-altering changes. And what we've tried to do here is really make the case that IBD patients should also be prioritised alongside other patients with cancer and other types of problems, particularly those with aortic aneurysms, in terms of being offered access to theatres. Again, just to think a lot about the vulnerability of the patient, alternative treatments where they're available, and how you might safely get them through a hospital admission. Next slide, please. So we've been very keen to try and promote and support research. And the reason for that is really to make sure that our very research active membership continues to participate in research, but also that they have access to high quality studies that will contribute to early data coming through. And I'm pleased to share with you this evening, next slide please, Ran, the early data from COVIDSurge, which just gives us an inkling of what is happening in terms of surgery and the risks for patients undergoing surgery during the surge of the pandemic. So let us just look over to the left-hand side of the slide where the small number of elective patients are involved. The overall study is looking at the first 250 patients in COVIDSurge, of whom 68 were elective cases. Of those patients, all of whom developed coronavirus and COVID-19 afterwards, 1/3, roughly, did not have any pulmonary complications. And they had a mortality which would be very similar to that which they would normally have expected. Unfortunately, the 2/3 of elective patients who developed pulmonary complications had a very high mortality rate of just under 24%. It's really food for thought when counselling a patient, and important to bring in to the consent and discussion about whether surgery should be deferred or go ahead. Next slide, please. So in view of this, we've also tried to start looking at how we might design services going forward for patients who have or need elective colorectal surgery. The priorities we've used are slightly different from those recommended by Gordon Carlson in his recent DCR publication, but what we've gone with are priorities which have been used by NHS England and will be very shortly published. So we're only looking at priorities 3, 4 and 5 here for elective surgery, as 1 and 2 refer to emergency and urgent cases. However, we do really recommend using Gordon's suggestion of assessing vulnerability of the patient from those who are not vulnerable to those who are most vulnerable and may be compromised in the event of contracting COVID-19. We also think it's important to consider the environment. There's a lot of talk now about green sites, clean sites, COVID-free sites, and how we might use some of these services. That certainly would be a good environment in which to work, but it will not mean that the environment is entirely free of COVID, well, certainly not for very long. Alternatively, other environments are those where services are segregated on the same site, and a high-risk environment would be one where there was a high prevalence. In terms of preparing the patients, we're suggesting 14 days of strict self-isolation and screening to ensure no symptoms, a test within 48 hours of the procedure, which unfortunately will yield some false negatives, and also a CT chest done within 24 hours to look for evidence of pulmonary complications. Now, this goes very much against the Intercollegiate and Royal College of Radiology guidance, which is only suggesting a CT chest for patients with upper GI cancer and with liver cancer, but we feel that it's actually the risk of developing pulmonary complications is the problem, and that is a COVID-19 risk, not a surgical risk related specifically to colorectal surgery. Next slide, please. So in all of this, we have a lot of very worried members trying to do the right thing and not sure about what they should and shouldn't do in any situation. And of course, it's evolving as rapidly as we can imagine. We've tried to be very supportive of our members and have put out a number of statements in support of them and their activities. Next slide. A major part of this is bringing forward some work that we've been doing for the last year in terms of developing a network for consultants in their early years of practice. The task force has done their work, and elections, the nominations are out for election at the moment, and we should have elections starting next week to get this group in place, up and running as quickly as possible to support the younger members of our colorectal community. Next slide, please. Angus.
So both patients and colleagues are feeling pretty disconnected at times at the moment, and we have to think of different ways that we can engage our patients. You can revert to the good old Scottish invention, the telephone, and we use a lot of telephone consultation. Indeed, here is my sign that I put on the door to say, please do not enter, consultation happening. So telephone consultation is a great and simple way of connecting with patients. You can use video consultations such as the Attend Anywhere or NHS Near Me system, and that gives you some visual cues and gives you some more information if you've got that bandwidth connectivity. When I was traveling in Malaysia last year, our colleagues, surgical colleagues in Malaysia, are big fans of WhatsApp. And so you could be in the middle of the Borneo jungle and you'd be getting information, sharing ideas and tips and consultation using WhatsApp. And that's a great tool, and there are other tools available just to keep in contact with your surgical team, your wider surgical team, to make sure that everyone's okay. It is a stressful time. I've certainly felt different and stressed and slightly depressed at times, and there are organizations that can help you, can support you, such as Breathing Space. There's lots of online help. And I think it's really important to complete a bond with your peers. So a virtual beer on a Friday night, even though you're socially isolating, you can have some of the Watson's homebrew to cheer your spirits. Next slide, thank you.
Thank you, Angus. So all of this is partly about bringing us towards a way to think about recovery, planning for recovery. And there's lots of work happening at the moment, which is really thinking about how we can best achieve that and avoid the late legacy of patients who have been poorly treated, badly treated, maybe suboptimally treated during the process. We also need to think about our workforce and the impact on our workforce in the long term and keeping morale up as well. Next slide, please. I'm going to hand you back to Neil for the last bit about what colorectal disease is doing.
Thank you, Nicola. Unsurprisingly, COVID has generated a number of research studies, but also a number of people wanted to communicate their early research findings. And we think it's important to process this very quickly and also to facilitate the processes through journal submission and review. And we've got a team dedicated to doing an expedited process for things that are submitted and are related to COVID-19. Wiley, the publishers of colorectal disease, have committed to making all articles that are published on the topic through colorectal disease or anything else free to access. So it's not behind a paywall and anyone can access it anywhere in the world. And we will have the first collection curated together of the publication in the next month or two, a special collection within colorectal disease, so everyone can find it in one place quite easily. And the link to the coronavirus online resource is on screen there. Thank you very much. That's the end of the presentation for now, and we're going to revert back to perhaps which is the most important part of this webinar, and that's really the discussion. The questions have been coming through already, and unsurprisingly for a group of surgeons who have dialed into this, most of the questions are of a very pragmatic nature, and it's very clear that surgeons are very interested in the prioritization concept. And I'm going to start with two questions. We'll take them one at a time. But it's about the environment concept that Nicola mentioned. And the first question is, we're talking about operating in a COVID-free environment. How do we achieve this without regular testing of those staff involved in the care of these patients? Very topical. And thought I'd start with you, Nicola. How do we make it a truly COVID-free environment? Can we make it a truly COVID-free environment?
The question is absolutely right. Until there is widespread testing of both patients and staff, we're not going to know that it's going to be, I think in many ways, COVID light would be a better way of explaining the problem, because we also know that some people test negative and then test positive at a later date, often just within a couple of days, which is why some people are recommending two. And with people off work, particularly from exposure, it's difficult to know whether they will be able to work in that sort of environment. So you're right. I think delivering a COVID-free environment is incredibly difficult to achieve, particularly without good testing and without really good segregation. The screening processes to allow people through the door will have to be really rigorous in order to maintain that relatively COVID-light environment. Because the whole point of the pandemic is that it is endemic. The problem is there, it's all around us, and many people are asymptomatic. And we know that already. So it's a very good question, and how we achieve it is difficult. I think the other thing to say is that it's may not even be achievable in many places where there are not the split site resources available in some institutions. Some of the bigger cities, it may well be. Some of the smaller ones, it's going to be very difficult to achieve.
Thank you. Angus, would you like to comment as well?
Yeah, so you can't eliminate the risk, and the risk is there, but you can do everything you can to reduce the risk. And what do we have? We can reduce the risk for our patients who are coming in, and we can try and reduce the risk of to our staff, both the staff bringing in infection and then transmitting infection amongst healthcare staff. So I think I agree with Nicola that that testing of staff as well as patients is going to be inevitable to try and reduce the risk, but we can't eliminate it. If we can produce environments which are relatively virus-free, and then that seems a sensible measure, but that's very resource dependent, and a lot of areas within the UK and internationally will not have that luxury. So I think it's about reducing and mitigating risk.
Great, thank you. John?
So I think the issue about staff is important. One of the striking things on the Thursday call out is the pictures of dozens of NHS people standing right next to each other. Certainly in our hospital, we have people cramming into small rooms for a handover. I think all of us feel slightly immune to this problem and still work in the way that we have done before. We have to remember that social distancing is something that we need to do within the hospital as well as outside it, but we need to take care of each other's personal space and obey the same rules that we insist on everybody else obeying. And certainly in my hospital, and certainly on the pictures on the news, this is not done. And there's no doubt that doctors and people in the hospitals are one of the major vectors for spreading the disease around within the hospital. So I think we have to take great care and be really conscious the whole time of the problem. The other thing I'd like to say is about testing. I don't think that you can test everything and everybody all the time. There's a national and a world shortage of reagents. The reagents are often made in China, and the idea that we're going to be able to test everybody all the time, and that is the answer, seems to me to be possibly naive. Ultimately, we're going to be very selective about how we test, and the pathway that Nicola's described, I think, is a really good start. But we're going to have to be, we simply can't power our way through this. We've got to be really selective, constructive in what we do.
Okay, there's a couple of comments coming through relating to team working in this environment and actually building teams working closer together, and actually morale might be higher. Possibly, interesting thought. But what has come through as a question is the coming back to the concept of a cold site. Is, are any of the panel happy to do a segmental resection in a private hospital which doesn't have critical care facilities? An interesting conundrum, and I know the concept about using private healthcare facilities has been mooted by the government and has happened in some parts of the UK. John, what's your take on that?
Well, I gave up private practice years ago because I found that operating on a major case and then leaving in the middle of a wood was absolutely terrifying. And I would really struggle with this. The power and speed of the rescue systems are critically important to managing an anastomotic leak. Our local private providers have been very helpful, and our team have been doing these sorts of resections in those hospitals. The larger ones have got ITU facilities, and we are arranging for trainees to be on site. So provided the rescue mechanism is there, then I see no reason that we shouldn't do it. Personally, I gave up this sort of practice years and years ago, wouldn't be keen to go back to it.
Okay. Angus?
So the nearest private hospital to Inverness is many, many miles away, thank goodness. But we do have remote and rural community hospitals who do have operating theatres and critical care beds, but not many. And so we are actively considering how we might manage that to make those hospitals, which aren't too far away, are green sites, and whether we could manage that. But it's the logistic challenges and making sure that there's capable staff on site, not just to operate, but as John was saying, the legacy, looking after patients until they're discharged to do that rescue if needed.
Okay, Nicola?
I don't think I have anything to add than what's been said already, Neil. I would urge each surgeon to really look at the environment with a completely different perspective, and work out the safety of that patient in every possible way, whether it's from COVID, contracting COVID-19, whether it is the failure to salvage afterwards. I can see questions come up about why would you want to do a stoma rather than anastomosis? Well, anastomosis is exactly that. It is a way of not making a stoma. That's what it means. But it also carries a risk of leak. And if you have a risk of leak, you have less chance of an ITU bed, less chance of access to theatre in a timely way to salvage that leak afterwards. Your mortality is going to be higher. And if you're then admitted to an ITU where COVID-19 is endemic, you're very likely to get it, just from the fact that a lot of the infections we're seeing at the moment, particularly the symptomatic patients, are those who've acquired it as a hospital-acquired infection, so as a nosocomial infection. We can add more to that. So just judge the environment, think about it very carefully, document your concerns, discuss them with the patient.
Okay, so that was very much about prioritization. There are other questions that have come up about the pragmatics of getting started and patient selection, and particularly the preoperative workup. And there's a few which have come through about the CT scan concept. One in particular from a colleague who's well known to us all has said that a very strong statement from Nicola and really helpful on CT chest and pre-op testing. Do we say this or no surgery? And someone else has commented, CT chest pre-op, radiologists want to follow the RCR advice, we want to follow ACP advice. Help! So how do you proceed? How do you have those negotiations with your radiology colleagues in your hospital?
I'm going to take that, if I may, Neil, because I feel quite passionately about this, that we were signed up to sign it up to essentially a piece of work of which we knew nothing about until it was then subsequently published. So let's just split the question into two parts. The first is about CT chest in the emergency patient. Any patient who is admitted as an emergency or an urgent case and has a CT, the agreement is that they will have a CT chest at the same time. And certainly from my understanding of talking to people around the country, that is now happening in most places, even when they haven't actually asked for it, as a way of screening before the swabs come back. So in other words, you've got a better idea of how to place the patient, how to treat the patient, what might be wrong with the patient. This is a slightly different question. And at the time when the advice about not using CT in pre-op came out, we did not yet have that data from COVID Surge in the public domain. And I am very hopeful that now that I have shared that, courtesy of COVID Surge, with the presidents of the Royal Colleges, that they will be in a better position to explain to the Royal College of Radiology, who are actually the brakes on all of this, that actually it's not about the pulmonary complications associated with the procedure, it's about the pulmonary complications of COVID-19. And that is what influences mortality. So rest assured, we're on it and we will continue to work on it. And I very much hope that you will see a revised statement in the very near future.
Okay, John?
The penalty for operating on somebody with COVID disease is so high that certainly if I were going to have an operation, this is a precaution I'd like to have made for me. The radiology departments are, on the whole, not busy at the moment. So much of their outpatient and inpatient traffic has gone away. So it's not a problem of capacity, it's a problem of philosophy. And I think that data from COVID Surge is very, very clear and makes the argument very strongly, as Nicola has said.
And Angus, in Scotland?
So we've been debating this today, actually, because I saw the COVID Surge data from Monday's Edinburgh College webinar, and that Nicola kindly shared, and that's convinced me. And I think up to that point, I wasn't sure that there was enough evidence, but now I am convinced. So we don't currently do CT chest in the elective setting. But I think we should. And so tomorrow we have our consultants meeting and we're going to bring it up and involve our teammates in radiology to see how we do that. So I am now convinced, and that's the power of data that's coming out through research.
Okay.
And I think we also have to acknowledge some of the things that the radiologists are concerned about, Neil, because we've got to see it from the other side. Some of the arguments that were put against using this are that we will pick up a lot of DITSLs, which might require interval imaging. Who cares about DITSLs when you're facing a mortality risk if you've got lung changes? They also say that there isn't the evidence there to support this recommendation, but there isn't actually any evidence not to support it. It's a bit of a common sense way of screening things, and certainly we've seen colleagues in China and Italy use it very effectively in this way. And the final thing that they're concerned about is too much radiation and the long-term cancer risks. And again, I don't think that that's something that can be argued about when you're facing a mortality in front of you versus the possibility of a 1 in 1,000 future cancer. I think most patients would know where they lay on that one. So we'll keep at it.
Now, you very nicely highlighted the issue of absence of evidence is not evidence of absence. And that brings us to the very thorny topic of laparoscopy. And there have been a number of questions that have come through regarding laparoscopic surgery, and is it recommended? Is it not? Should we be doing it? There have been a couple of comments that have come through about the released ALS GBI guidance, which has come out earlier today. Where do we stand? I'm going to start with Angus.
So we are delivering colorectal surgery in the public health environment. And so it's not about whether you're a supreme racehorse who can take anything out with a laparoscope. It's about how we do it across units. So I am firmly of the belief that we shouldn't be doing laparoscopic colorectal surgery. I accept the evidence is weak, and I've looked at the papers this afternoon, and there's not a huge amount of evidence either way, but it's quicker. You may be operating with colleagues who are not colorectal surgeons in particularly hard-pressed areas, so you may be operating with surgical practitioners who are not familiar with the nuances of laparoscopic colorectal surgery. So we're bringing the denominator down, and it's what's safe, it's what's quick. And remember, surgery is a team game. It's not about the surgeons operating, it's about protecting everyone in the operating theatre. And we don't know whether smoke contains virions or not. So I firmly back the ACP stance.
Okay, John? My understanding is that there is evidence that smoke, even diathermy smoke or the energy devices at open surgery, will produce aerosol effects and can produce viral particles that can be detected even days later on surfaces in theatre. The other issue in theatre is that most of ours expel air rather than pulling it in. So you're blasting whatever you're making in theatre out through the doors, usually into the queue of people watching to see how you're getting on. I think that the evidence coming through from COVID surge that if you operate a clean site, you get very, very few cases of COVID suggests that in that context and using that sort of pathway, you could be sufficiently confident that you've not got an infected patient, that then laparoscopic surgery becomes much safer and much less of an issue. So I think if you could set up a green site and a team that are used to it, and a system that is reliable, then I can't see a strong objection to it. In the emergency setting where things are much less clear and everything is under much more pressure, I think there's very little place for it unless there's an exceptional case. So I think compromise is going to come. The other thing is we're going to have to get back to some form of normal, and that is not going to happen for a long time. We're going to have to live with this virus for years, and I don't see us withholding laparoscopic surgery for years. So we've got to find a way to work this, and fairly soon.
Okay, I mean, I would have to say, and just to add into that, certainly the standard colorectal theatre team that I would normally do my laparoscopic resections with have been disrupted. Colorectal theatre has now been moved to the orthopaedic block. We have nurses from ENT, Max Fax, orthopaedics in the theatre helping out. So certainly a team familiar with all the laparoscopic kit at the moment is just, it's not quite there. And I saw the ALS guidance earlier today, and some of the things that they've been talking about are not on the shelf in my hospital. I don't have all the fancy ports. So should I be starting to do laparoscopic surgery again? Nicola?
I think we have to come back to the fact that we don't yet know. We do know that we have 3 potential sources, and colorectal surgeons are exposed to all of them, whatever form of surgery they're doing. And that is certainly, we know the airborne, we know about the bloodborne, and we know about the fecal transmission as well. And a lot of our statement was about keeping people safe, as Angus says, in an environment which is extremely risky to both patients and to surgeons. And we're not necessarily aiming at the very highbrow expert laparoscopist who may be able to work in an environment which is being protected from some of what's happening in the rest of the country. We're aiming at trying to keep the majority of surgeons safe, whilst we simply do not know whether it's safe or not. And it's much more of a public health issue, exactly as has been discussed. We also have to look at where some of the evidence that has been quoted has been generated. And it's been generated in healthcare systems which are not those that we enjoy. For example, the negative pressure environments that most Australian theatres have are not what the average UK theatre has. It's a completely different environment. So whilst we're still accumulating evidence, I think we have to use a more generic approach and make people at least think. We've given enough wriggle room. There is enough wriggle room. If you really, really think that it's safe for you and it's safe for the patient, then that is fine. But think about the other healthcare staff in the theatre with you as well. It's not just about the surgeon. Thank you.
I think that's very important, and we all have to bear that in mind. Now, if we're just going to move on a little bit further, some of the questions coming through are related to what happens in the post-operative setting, relating to patients who might need high dependency or ITUs, and are they at risk of catching nosocomial infection? And I think in part we've already dealt with that through the presentation of some of the data from COVID surgeon. I know that's still accumulating. Should those patients be going to dedicated facilities which are clean? Should they be going to wards which are clean? How should they be dealt with in the post-operative setting? What pathway should they follow? Nicola.
So these are mostly about emergency patients who've been admitted and you simply don't know their status. And that's the bottom line. When you're operating on them, even with a CT chest, which is fine, the swabs usually take 24 to 48 hours to come through, and you may have a false negative there as well. I think you still have to make the case for high dependency or critical care provision for an emergency laparotomy, just as you would do normally. NELA is still collecting data, and they have not relaxed any of the guidance around it. But I don't think that there is any reason not to document very carefully if you cannot get the care that you would normally to give to the patient, is simply to actually make sure that you do your best to get them to a level of care where they're safe. And if necessary, we've been having patients back on the ward and looking after them ourselves with our own teams, trying to give that additional level of care, often with anaesthetic or ITU advice given remotely in terms of monitoring the patient and making sure they're right. If it's more than that, then it has to be discussed on its merits, and I think you're perfectly within your rights to ask for a patient to the right place. But the truth is that there isn't an intensive care unit in the country which is clear of COVID. There is going to be a risk there, but they do have the best possible protection. They're the best set up in terms of isolation of both staff and patients. And if your patient is repeatedly tested during the course, I think that they can come back to a surgical ward, provided that's what your local ID advice is at the time, and step down in the normal way. One other thing we mustn't forget as surgeons is any patient who's come to hospital, who's been treated in hospital, has to be given the advice to self-isolate for at least 14 days afterwards, because they've been in an infected environment. And also not to forget that those who are vulnerable need to be told to permanently self-isolate. And it's an important part of our discharge planning now that we should incorporate those nuances of the environment in our discharge planning.
Yeah, that's good points. If I may, I'd like to move the conversation on, because we've still got a number of different questions that are coming through and are quite interesting. And I'd like to go back to the very, I suppose, early part of the pathway. And the question's been asked, what are ACP and the colleges doing about those patients with abdominal symptoms sitting at home for fear of coming into hospital at the moment? Any public announcements, any plans? The fear of the surge in COVID is particularly important for patients who have got significant intra-abdominal pathology. So what are we doing about that group of patients? How are we reaching out to them? Angus.
I think it is a real fear. We've seen a very dramatic drop-off in referrals from general practice along our lower GI pathway, so that there are undoubtedly patients who are sitting at home, feared of going to the GP, and feared of coming into hospital. Our A&E admissions locally have gone down to less than a third of what they were. And so there are undoubtedly patients who I think will come to harm because they're not seeking appropriate health care. I think our message is that if you have got symptoms, you must seek help. We are still open for business. So you must go and speak to your general practitioner on the phone or physically go up to a medical centre and to be seen. And that if you are unwell, you should attend A&E, or you should, your GP should refer you in. There are lots of different ways that we can mitigate risk. We've talked about that today. And so I'd strongly encourage the public to continue to seek help if they're suffering.
Okay. And John?
I think that's right. I think the politicians are trying. At the Downing Street briefing today, they've again mentioned that the NHS is there to treat the sick, and that's what we're here for. But it's a fairly small part and gets swept away under this tidal wave of bad news. I think the colleges probably need to engage with the media. It's the media is the way to get our message out there to the public. And that's we have pretty good relationships, both colleges, with the media, and that's probably the best that we can do. Ultimately, it's a problem for the health service and the patients in getting them to the right place at the right time. The other thing is the excess mortality across the whole population has been reported the last 2 weeks. Some of that is clearly going to be emergency patients who are not coming, but some of it is going to be these patients just decompensating with their other medical illnesses around rectal bleeding and whatever. It's a real problem. And most of the patients I ring up are just terrified. They don't want to come anywhere near the hospital. They think it's deadly.
Okay. And Nicola, from an ACP perspective?
So this is a very important part of what we're trying to do. Maintaining emergency general surgical services is absolutely key to looking after a large proportion of patients who otherwise will have very poor outcomes during the pandemic. We know during the first big SARS outbreak in 2009 that a lot of the excess mortality, which was attributed to SARS at the time, was actually due to sepsis. And as surgeons, particularly those of us who deliver emergency general surgical services, what we do is help save lives in terms of dealing with intra-abdominal sepsis as a major source of morbidity and mortality. So we do have to keep that open, and that is one of the reasons why the early intercollegiate advice really prioritized making sure that you've got services up and running, and we concentrated very much on safe surgery within the EGS environment in order to make sure that those services were safe and effective. You're right. I think John's right that this is largely a political message, a media message that has to be got out, that it is still safe to come if you're unwell. And it's not just EGS, it's also those patients with MIs and strokes who we suspect are largely being palliated at home.
Okay, so to move forward then, the patients are being referred, and there's a number of questions about what next. And many people have commented about FIT. And questions include, can FIT be used as a triage tool to discourage a 2-week waiting referral in the first place? Or FIT is not universally available. What do we do if we have to triage without FIT? And if a FIT is negative, do the patients then have prolonged deferral before they're re-referred? So how is FIT going to be used in the community now for many of the referrals that we're going to get? So I know Scotland has got some plans. So Angus, I'm going to put that in your direction first.
So we have rolled out FIT testing in primary care throughout almost every health board in Scotland. So we have quite a good experience. And a lot of the original work was done by Craig Mowat and his team in Tayside. And so we know that the negative predictive value of a fit test that's less than 10 is very, very good. You've got a 99.5% chance of not having anything significant if you haven't got iron deficiency anemia or you haven't got diarrhea as a predominant symptom. So we've been encouraging primary care colleagues to reassure patients in that scenario. 80% of fit testing done in that way will be negative. So 20% are positive, and 4 or 5% will be that high band of over 400 micrograms per gram. And that, when you get to that level, you've got a 50% chance of having significant bowel pathology. So I am a firm believer that FIT is an excellent triage tool. It will allow us to prioritize patients with those FIT 400 into earlier diagnostics when normal business resumes. And it may be able to, to reduce the risk and to reduce the tsunami of referrals, which I think will come once we get back to a bit more normal business.
Yes. John, in England?
So we've been using FIT in Nottingham for some years now and agree completely with what Angus says. I've seen the pathway from London, which is largely based around it. I don't think we're going to get back to normal. As I've said before, I think this virus is going to be around for a long time, and lobbying your local CCGs, your laboratories to get FIT and to get that pathway in place seems to me to be a solid investment for how you're going to deal with this going forwards. We are not going to return to what we thought was normal practice for the foreseeable future. So building ways to manage patients without bringing them up to the hospital is really key.
Okay. And so in terms of if we do have to go forward with investigations in light of a positive FIT, what do we do? And there's been questions about should we be doing more colonoscopy now? For some people thinking if we're over the peak, should we be looking at more CTs? And what role does colon capsule endoscopy have? Nicola, what's your take on how to deal with these patients who've got positive FIT tests?
Okay, so let's just think about some of the alternatives. So the guidance we've just written with BSG and BASGAR, the BASGAR group are very, very clear that a plain CT with IV contrast will pick up 85% of patients with cancer. That's not a CT colon, so that if you've got a patient who is highly symptomatic or who has a very high FIT test, if you've got no other way of making a diagnosis, then it's a very good first port of call in terms of getting an answer. CT colon, there is concerns about what it actually involves and the potential risks that it carries both to the staff, mostly to the staff, not so much for the patient. But again, in some places which have relatively green or clean environments, particularly in the private sector, a lot of London hospitals have reopened to doing some CT colonography in order to try and deal with the backlog of this highly selected group of patients who are now coming through on the cancer pathway. And then we need to give some thought to how we reintroduce colonoscopy. And that is a particularly important piece of work. And to some extent, we don't have enough evidence, particularly around how much PPE and what PPE precisely is required for colonoscopy. Whilst there's no doubt that gastroscopy is an aerosol generating procedure, we're not entirely sure about colonoscopy, although again, there are some intuitive risks that are potentially involved. I think we will see technology playing a major part in terms of new devices to protect both the patient and the theatre staff. We will see much slower turnaround because every patient will need to be treated as though they're COVID positive. I've seen some initial plans which talk about managing to do 4 colonoscopies in a day, with the theatre cleaning and the equipment cleaning that will need to be taking place afterwards. And of course, access to PPE will have to be factored in. If it's not available, then the colonoscopy services are not going to be able to happen. And I definitely think we need to hand this question over to Angus next to talk a little bit more about his work on the colon capsule.
Thanks, Nicola. So colon capsule has been around for a while. We have been doing an evaluation of colon capsule up here in Inverness and the Highlands, and we're nearly up to 500 patients in that group using FIT in that pathway to triage patients. So if you have a FIT of 400, you will not get a colon capsule. So we've been trying to triage the group that between FIT 10 and FIT 400 and putting them through a colon capsule. Now, colon capsule is done after bowel prep, just the same way as colonoscopy, but it's done in the community. It doesn't need any specialist equipment other than the capsule and the belt detection equipment. So we've set up local hubs across the Highlands and Islands, which suits our geography, so patients don't have to travel. But it's a technique that's readily transferable. And I would very much hope that locally, both here in the Highlands, but elsewhere in Scottish Health Boards, we can use colon capsule as part of that recovery so that we can triage patients away from endoscopy units. So our early experience is that we'll save about 70% of patients from needing a colonoscopy after their colon capsule endoscopy. And we can, because we've identified the pathology, we can then triage them to, well, that's a routine scope in many months' time, or you've got a significant polyp or a cancer that needs urgent diagnostic colonoscopy.
Okay. I think going forward, there have been a number of comments about, for want of a better phrase, legacy from COVID. It's clearly a topic which has generated a lot of thought, and many people have started to think about how we exit from this. So a couple of comments that have come through about the implementation of things like QFIT into the pathway seems to have been about, should we be looking at the guidelines for colorectal cancer to eat weights again? Should we be looking longer term about standardizing how we deal with laparoscopic surgery and evacuation of the plume that's generated during that type of surgery? Should we have stronger recommendations about open surgery and smoke evacuation? What can we take forward and what can we learn from COVID? John?
So I've been, in preparing for this, I've been listening to an American epidemiologist called Osterholm, who's done a series of podcasts that are very informative. He's very, very clear that we're going to be living with this virus for the foreseeable future. So really, we have to adapt our systems to that. So with the colonoscopy, we're going to have to try and ensure that people are COVID-free and have a green pathway analogous to what we've had before. Fundamentally, all of these questions are about how you ameliorate the risk and to make the thing as safe as you can whilst trying to get the throughput back to what we used to do. I don't think there's a simple answer to any of these questions, but adapt and evolve, but don't expect it just to flare and go away. That's not what's going to happen.
Nicola?
So I don't think things are ever going to be the same again. I think healthcare has taken a quantum leap in a different direction, which has both brought amazing opportunities, but also a lot of fear and anxiety, which has a particular effect on people in the workforce. So some of the positives are things have changed so quickly. We've seen governments change, we've seen trusts change, we've seen individuals change their practices and adapt and learn and do things differently. And in that, we've seen some good things. We've seen a much more patient-centered, patient-focused care being offered, which has been very much about the patient, keeping the patient safe, about how you communicate with the patient, not bringing them necessarily to a hospital appointment so that it suits you, but having a video conference with them, still being able to get a lot of the cues. So I think some of those things will be here and they will change the way we continue to work going forward. I think that in terms of innovation, we've seen the most extraordinary examples of people switching 3D printers to doing something different, to using different ways of approaching things, to fast tracking. Even NIHR research money has been fast tracked into areas where it's really, really needed. These are good things that show that actually we can do things properly when we need to. But is it going to change our lives? Yes, as John says, it's here, and it may not be this one, but there will be another challenge. We need to start preparing now for the next big thing that might be around the corner. And that's going to be a major part of the legacy, is really thinking about the structure, our resilience, our responsiveness, how we make things happen when there is truly a pandemic emergency. And that's what this has been. But likewise, as a community, we will probably see less in the way of international travel, more connections like we're doing this evening. Certainly thinking a little bit about what those additional risks are, thinking a bit about the impact of surgery on the environment, things we were already starting to look at in terms of green surgery. How do we make it better, not just safer, but better as well? There's so much out there which has still got to be dealt with, which will be part of the legacy. Some of it good, some of it less good, particularly in terms of patients who've done badly.
Okay, I'd like to just move on for the sake of time to, I suppose, two topics towards the end. And the first of these, I think, is a topic which is very dear to all of our hearts, and indeed all the colleges as well as ACP, and that's to do with our trainees. And I would like to think that as colorectal surgeons, we've had an excellent relationship with Duke's Club, and colorectal trainees in particular have been really at the forefront of driving some of the developments in our specialty over the past decade or so. But understandably, there's a lot of anxiety amongst colorectal trainees in particular at the moment. And as we've alluded to, this isn't going to go away quickly, and there are going to be other challenges to come. So it has been asked, what will be the training in the coming months to years for colorectal surgical trainees in the UK? Angus.
Well, Neil, I'm a pint half full kind of guy, and as Captain Tom says, the sun will shine again. So I think we need to flip it on its head and say, what can you learn from this time? What have you learned through the pandemic? How have you worked differently in the team? How have you worked in different specialties? What have you learned when you've been doing a shift in ITU or an accident emergency? And the fact that you're not doing colorectal surgery or on the tools, you're not, it's not because you're not learning, you are learning other things. And that's my main message, to say, have an open mind. You know, the sun will shine again. You're a long-time consultant, so you will get trained. We will make sure that you are well trained, but keep your mind open to other opportunities and other skills that you can acquire along the way.
Good. John?
I think that's right. I think in the short term, there's going to be something of a hiccup whilst people have clearly not got any operating and getting into the operating room and their diaries and logbooks are not where they would want to be. In the longer term, I think it's just going to, we're going to have to think really hard about how the trainees work and what it is they do and make sure that we maximise their experience. When I grew up, we were the ones that delivered the service. We're absolutely crystal clear that they are there for training, and we need to protect that as much as we can. I know that conversations are going on between the colleges and Health Education England and JCST. We look forward to seeing what they come up with. As Angus says, just because you're not actually in the operating theatre cutting doesn't mean that there aren't really useful transferable skills that you can learn in other contexts. Yeah.
And Nicola?
I would agree with everything that's said at the moment. We have urged our members to remain connected with their trainees. They might not be working with you, they might be redeployed, but really to maintain those connections, maintain those contacts, particularly between educational supervisors and trainees. It's a key relationship and it needs to continue even as the trainees are learning other things. There is so much opportunity, as Angus says, both in terms of learning new skills. I mean, for heaven's sake, I've learned new skills. I've had to learn how to restring a violin during this time. It's something I never thought I'd have to do. We're all doing different things and learning different things, and there are educational opportunities galore. It's a good time to get on top of those, write those papers, get things done, and just think about the world a little bit differently. It will come right in the end.
Okay. There's one final question that I think we should take before we finish and wrap up. And it's one which probably reflects the anxiety of the time. And it is, can the panel comment on the medical legal implications for decision making that is necessarily different and not in line with best practice? What will happen in 5 years' time when these cases are being looked at by lawyers and expert witnesses when the COVID pandemic is history?
I'm going to ask if I may take that. I think the important thing to remember is to go back to the very first letter that came from all the chief medical officers and from the GMC. It made it incredibly clear that things would be different, that you would have to do things differently, and that nobody, provided they were demonstrating that they thought they were doing the right thing for the patient in front of them, it's always about the patient in front of you, is actually going to be found in any way wanting, provided they can demonstrate that. My additional advice is that everything should have a context to it. So every MDT record should actually have a note at the top saying this decision was made during the COVID-19 pandemic, and if you can put a face to it, even better. Make sure that that's clear in all the documentation, in every letter that you send to a GP and every letter that you send to a patient. You're making the context clear at the time. And if you're doing that, then you are going to be protected. And there's, of course, it's anxious making, and of course, lawyers will have a look at things afterwards. But you have to remember that you're being judged on a different set of circumstances.
Yes, John?
I think that's absolutely right. The other thing I would say is about the use of technology and WhatsApp and talking to patients that way. Data privacy is a big thing in the health service, and hospitals do not like this sort of thing. But there is NHS guidance out there suggesting that we do use these techniques and these technologies, and that provided it's in the best interest of the patient and you're taking appropriate steps, that's fine, and there's not a data breach issue.
Okay. And finally, Angus?
Colorectal surgeons are team animals, so we have to work with a team. We have to document, as Nicholas says, our decisions as a team, discuss patients widely, and document your discussion. I think that's a key thing. It's great for patient care, and it's great for morale and peer support.
Brilliant. Thank you. We're past 8 o'clock now, so I think we should be drawing to a close. I'd like to thank my panelists for their time and effort that they've put into preparing for this. So thank you all very much. And I would like to thank the many hundreds of you who have dialed in. And I would also like to thank the Royal College of Surgeons of Edinburgh for hosting this webinar. It's good night from us. Thank you very much. Bye-bye.
Good night all.